Good afternoon, everybody who's watching. My name is Dr. Buerki, and I'm a neuro-oncologist with Northwestern Medicine. I'm a board-certified neurologist as well as a board-certified neuro-oncology subspecialist, and I see patients here at the Warrenville Cancer Center. So today we're going to talk about neuropathy and cancer and nerve damage caused by chemotherapy agents and other drugs. All based on past Facebook Lives from LivingWell patients. I'll start with kind of a short presentation and discussion, and then we'll have plenty of time for questions from patients about symptoms and management of this important topic. So first, what is neuropathy and what is chemotherapy-induced neuropathy? So neuropathy simply means nerve damage, and when we think of neuropathy in the setting of cancer, we generally are talking about the peripheral nerves, so nerves in your arms and legs, fingers and toes, rather than something like damage to the brain or spinal cord. Peripheral neuropathy can occur from many other diseases as well, and when we have cancer patients who develop this, part of our evaluation is to assess, is this actually related to their chemotherapy treatment or other treatments they've received, or could this be something else entirely, because the treatments and how those diseases progress might be very different. The most common types of neuropathy that we see in oncology patients is a sensory neuropathy. In other words, the nerves involved in our senses. And that includes touch, but also how we perceive pain, temperature, and how we perceive where our limbs and other body parts are in space. The term we use for that is called proprioception. Neuropathy can also involve what we call the motor nerves, causing weakness and loss of function due to certain other chemotherapy types. But the sensory nerves are the most typical presentation that we see. And lastly, chemotherapy-related neuropathy can also affect some of the nerves on the inside of the body, those affecting how our heart rate is governed, how our GI tract moves and functions, and that can lead to things like constipation or feeling that the abdomen is unusually full because things are not moving around. There are chemotherapy drugs that are well known to lead to neuropathy in many, if not all, patients. And for the most part, this is a symptom that develops immediately or shortly after the patient receives that treatment. In those cases, we want to be able to manage the symptoms of the neuropathy, and also make sure that especially if the chemotherapy drug is for a curative use in that cancer type, that we're able to continue manage the symptoms to continue treatment. For some other cancer types or other chemotherapy drugs, if the intent is not curative, maybe we would modify the regimen or the dose of the drug to help with those side effects. When chemotherapy chemo-induced neuropathy occurs, it will often last past and longer than the actual duration of chemotherapy, and sometimes even slightly worsen even after chemotherapy is stopped. We sometimes use the term coasting to describe this phenomenon, almost like there's no more, you're not pushing down on the gas pedal, but you're continuing to move. However, in most cases, especially with the common agents that cause this, such as platinum drugs, including oxaliplatin and taxane type of chemotherapy drugs, the symptoms get better on their own, even without treatment, after the patient has completed the course of chemotherapy. There can, however, be lingering symptoms and a chronic phase to the chemotherapy neuropathy as well that lasts much longer than all of the treatments patients are undergoing. During that chronic phase, we also want to establish again if this is truly related to that prior history of chemotherapy use, and if there's any treatments, symptomatic treatments at that time that can help patients as well. So what do we know that works, and importantly, what do we know that doesn't work? For the prevention or treatment of neuropathy symptoms while someone is undergoing chemotherapy treatment, we have not found anything that prevents this completely. Several medications, both drugs, prescription drugs that have been studied in clinical trials, as well as vitamin treatments and other herbal or supplemental therapies, have not shown to be effective at preventing it or even reducing the intensity of symptoms in some of these comparative trials. There are a few strategies that have shown early benefit in small numbers of patients that, when this has been studied by some of our large groups, oncology groups that publish guidelines both in the US and in Europe, that there's not a direct recommendation for, but we often feel that at least the safety profile and some of the early results are enough that this is something patients can consider. One of those, for example, is called cryotherapy or cold therapy, and basically it involves gloves and socks or stockings that help that are very cold and kind of prevent the flow of the blood flow and the chemotherapy going to those sites, those long nerves, while patients are undergoing it. It's not necessarily available everywhere, but for many patients, that's something that can be considered. The other types of therapies that we found that can be helpful include simple things like exercise while undergoing chemotherapy can help with reducing the severity of these neuropathy symptoms. When the neuropathy involves not only just a loss of sensation, so numbness or inability to perceive where that limb is in space, but also starts to include other symptoms like increased cold sensitivity, pain, including sort of pins and needles feeling and pain just at rest, as well as burning type of symptoms. Sometimes there are medications used for neuropathic pain that can be helpful in those situations. Again, these have unfortunately not shown that they're effective at preventing the development of chemotherapy-induced peripheral neuropathy, but they can help with some of these pain symptoms. And these medications, I would add, are also used in other diseases, for example, diabetes, where the development of peripheral neuropathy, including painful peripheral neuropathy, is really common. When patients have those symptoms, it is very reasonable to consider using some of those drugs as well to see if they help. In fact, only one of those has been explored and is recommended specifically for chemotherapy-induced peripheral neuropathy, and that's a drug called Cymbalta that's also used as an antidepressant. However, there's some evidence in smaller studies for some of the other neuropathic pain medications, for example, used in diabetes as well, that can be considered. One additional way that we can at least help with either preventing an established neuropathy from further worsening or potentially prevent it from becoming as severe while patients are undergoing treatment is to go through risk factors. And I already mentioned diabetes, which on its own can cause peripheral neuropathy, but certainly control of diabetes is important. Alcohol is known to be toxic to nerves, and that's another substance that I would recommend avoiding to prevent worsening of peripheral neuropathy. We want to make sure that patients' diet has sufficient quantity of both calories and vitamins that can be helpful. However, we are, especially while patients are receiving chemotherapy, we're not inclined to recommend very high doses of vitamins. A, in part because those haven't been shown to be effective at preventing the peripheral neuropathy, but B, and importantly, we are worried that those might interact with or even counteract the benefit of the chemo itself in trying to kill cancer cells. So there is a balance with symptom management, in particular while undergoing chemotherapy. For patients who have, and the other thing that I would add in terms of prevention is cigarette smoking, which can also contribute to toxic effects on nerves and control of high blood pressure as well, I would add. For patients who have established neuropathy, who've completed their treatment, in addition to Cymbalta, as I mentioned, and some of the other neuropathic pain medications that have been looked at in small studies, other interventions including acupuncture, use of what's called electrostimulation, or is sometimes called a TENS unit treatment, or scrambler therapy, has also been shown in small studies to provide some benefit. However, what we really need are much larger randomized studies, comparative studies, to see if these interventions really do help patients. At least for things like acupuncture and electrostimulation, there's very little potential harm to using those, and it's reasonable for a patient to try that and see if they benefit from it. So that's a broad overview of the peripheral neuropathy that we typically see. I would add that even though there are what we might call classic or expected either drugs or patterns of neuropathy that we might expect, there's always exceptions to that, and patients can have very different presentations or very different symptoms from those classic symptoms. In other words, a drug that might not commonly cause neuropathy, it's still possible, and even though in most patients sometimes these are symmetric and we think it's going to be in the fingers and toes more than other sites, it can occur elsewhere in the body as well. So even something that seems atypical, we would still want to evaluate to see if it's related to the chemotherapy. There are some tests that we use to help with the diagnosis, although most of what we use to do the diagnosis is truly based on the physical exam and neurological exam of the patient, as well as on that treatment history, what other diseases a patient might have had, and what chemotherapy, drugs, or other medications they're using. In some cases, a test called an EMG, or electromyogram, and a nerve conduction study can be used to help diagnose nerve damage. That's a study that's done in the outpatient setting that can really establish if both the degree of nerve damage, of neuropathy, and also what sites are also involved. Typically, however, we don't need to do more extensive testing, nothing like a biopsy or MRI scans of the peripheral nerves to make this diagnosis. As with many parts of medicine, treatment of chemotherapy and cancer-related neuropathy is truly multidisciplinary. So the medical oncologist or hematologist, a neurologist, even a neuro-oncologist, potentially even patient's primary care doctor might all be involved in prescribing treatments. But we also involve palliative medicine and what is sometimes called supportive oncology to help with management of these symptoms. And in particular, I already mentioned exercise and acupuncture. Even outside that typical medical setting, there's a lot of treatments, therapies that can be helpful that we want to involve in seeing if they can help with some of these symptoms. So from that broad overview, I want to make sure that we have time and that we're able to address questions from patients. And there are a few questions that we had even before starting the Facebook Live that we wanted to make sure that we covered. So one of the concerns that patients have, does stress contribute to these symptoms of neuropathy? And in general, I would say no. I wouldn't put the onus of responsibility or guilt on stress, and I would put it kind of squarely on the toxic drugs themselves. However, certainly if in the setting of stress there's poor diet or not a nutritious diet, increased things like drinking and smoking, that poor control of things like diabetes, that could contribute. So even if a patient is completely stress-free on a lot of these medications, I would still consider that it's the chemotherapy being the cause of those symptoms. When we're faced with some of these symptoms, and I might add, sometimes the pain can be subtle that patients experience, like a very subtle tingling, pins and needles sensation, as I mentioned. Sometimes it can be very intense, keeping patients up at night, preventing them from being able to work, enjoy other things. When the pain affects the hands and soles of the feet, it's hard to walk, put on shoes and socks, hold things. And depending on the severity of this, and in addition, if you have neuropathy that's affecting those strength nerves, those motor nerves that can affect things like walking, or being able to use your hand or arms. When we're faced with those more intense symptoms, there is a balance of is this something that is so substantial that maybe we should reassess the chemotherapy drug or the dose. And in truth, that's a very personal decision, both for the patient and their oncologist and their medical team. Depends on the cancer type and whether the treatment is really curative, and also maybe the other options that are available. Certainly, it's a discussion that's worth having, even if no changes are made, just so patients and their families and caregivers can feel that they've really that they really understand and have knowledge about what is happening. When patients do develop those symptoms during chemotherapy, as I mentioned, in many cases, they might improve on their own. It might take weeks to months after completing the chemotherapy, but we do see we do see substantial improvement, in particular with some of the drugs called taxanes or Taxols. So even with that in mind, sort of getting through the temporary phase of those symptoms, we can reassess later on if they've improved on their own or not.
I've got quite a few questions here too.
Okay, I'm here with Sue, one of the coordinators at LivingWell. So she's going to share some questions, and I'll repeat them.
Yes, thank you. One of the many questions is, I'm on oxaliplatin, I'm probably pronouncing that wrong. Does exposing myself to the cold cause any further neuropathy, make it worse? Or is it possible to endure the sensitivity? Is it okay? It's summer and I'm dreaming of a swimming pool.
Especially today, right? It's over 100 degrees here in DuPage County. So oxaliplatin, so the question was, I'm on oxaliplatin and I have a lot of cold sensitivity. Does being in the cold make that worse? So that is one of the very common chemotherapy drugs that we use that is classically associated with developing peripheral neuropathy. It often is in the fingertips, fingers, toes, feet, and sensitivity to hot or cold can be a big part of that. Even if those symptoms are worse in a cold setting or a hot setting, they're not going to make the underlying damage to the nerve progress faster or worsen on its own. So I certainly, if it's something that can be either treated with another a treatment that helps those symptoms, or if it's something you can manage without other treatments, absolutely swimming and any other therapy like that isn't going to worsen the underlying nerve damage.
Fantastic. Another question is, someone mentions, and this is just a kind of a good mention, I use the cold gloves and socks during Taxol, and I do feel that it prevented my neuropathy from being as bad as it might have.
So I think that's a very reasonable thing to do. Really, the truth is, and the beginning of both the American oncology guidelines and the European oncology guidelines will say this, and I'll repeat it as well. We don't have good enough data. We don't have large enough studies with sufficient numbers of patients to give perfect answers for these. And thus we have to use what we can from smaller studies. And this is certainly something, the cryotherapy, that has been shown to be useful in smaller studies. So if it's helping and it's available, I think that's really great.
Another question is the neuropathy rates for Kadcyla higher than that of Taxotere? I had no issues with 6 rounds of Taxotere, but having issues with the other treatment. Will this last forever?
So these are 2 drugs that are used in treatment of breast cancer. The answer to that is typically no. Typically the Taxotere or docetaxels, the generic name for that drug, has a lot more neuropathy than we see with antibodies. Antibody treatments. I would certainly follow those symptoms. As I said, not everything goes by the book, and patients aren't kind of cookie cutter copies of each other. So I would certainly follow those symptoms. If it's something that is continuing to worsen, symptoms are really affecting quality of life or function, then that might be a discussion with your breast oncologist. Is this something we can hold or dose reduce that drug to see if it helps with those symptoms?
Just going through these. Okay. Interesting question. Can you get neuropathy from a blood draw?
So if it's done correctly, I wouldn't be worried about that. Certainly, if during the blood draw there was kind of needle damage or incorrect technique, potentially. However, I wouldn't think that's the most likely scenario. Certainly, I wouldn't expect neuropathy in other parts of the body where that needle or that blood draw took place.
Someone is asking, is there any way to get into a study?
That's a great question. So certainly the answer is yes. We need more studies and we need more subjects, patients on studies. I will say in many of the treatments that are not prescription drugs, that are either herbal supplemental things, things like cannabinoids or marijuana derivatives. There still are clinical trials run at places like Northwestern to look at those things, and that even though those are agents, treatments that you don't necessarily need to come to a cancer center to get, like vitamins and herbal things. Certainly participating in the study as a subject will really help everybody for us to see, hey, do those things really work? And at least in the past few years, we are able to do more studies on things like cannabinoids, cannabis, marijuana derivatives that were not possible in decades past.
Another question is, how long after chemo should I wait before seeking a treatment plan or waiting for a resolution if I'm starting to have some brief pain in toes, as well as some cold feelings and numbness? So when do you? So certainly after, I would not expect things to resolve within the first few days after completing either the full chemo course or a single treatment. If it's been over a month since the last chemotherapy treatment and symptoms are persistent, that's certainly when I would bring it up and talk to either your oncologist, or if there's palliative care, supportive oncology involvement. I might recommend waiting a little bit longer before undergoing substantial testing and anything else if that's necessary. But certainly, if something is persisting for several months after completing chemotherapy, then it's very appropriate to look into that. Someone's asking, they have had COVID, but they were feeling some lessening of neuropathy with Cymbalta, and then they had COVID, and now they're having some pins and needles feelings again, ramping back up. Is there any correlation? Curveball
question. I think that there's a lot that we don't know about acute COVID and what's termed long COVID or kind of chronic symptoms. Neuropathy has been seen in long COVID, and I would not, I would consider that to be absolutely a possibility, that even if it's been a period, weeks, even months since that COVID infection happened, that later on there's some worsening due to the COVID itself. With that in mind, I would add, in terms of the kind of other diagnoses, other illnesses, a history of COVID is now something that we want to consider when patients present with these neuropathy symptoms. For treatment and evaluation of that, not within the oncology group, but with some of the neurology doctors at Northwestern, we are studying that very carefully and trying to have a broad understanding of how COVID affects the nervous system.
Last question, looks like, is there, I don't know if you can answer this, but what dosage of Cymbalta is recommended?
So I'd say a caveat, every patient's other medications and drug interactions might affect and other medical history might affect the dose of Cymbalta. Typically, a dose of about 60 milligrams is what we think of as the target dose. Many patients would see improvement at a lower dose and might not see any additional benefit for going up to 60. If somebody has had that, because that is one of the agents that we have, one of the drugs that we have more data for its benefit, If somebody has started that and they're at that target dose, I would certainly want to try that for several weeks before seeing if it's not helping. And I honestly might even consider going higher again if it is appropriate based on other medications and other medical issues to see if there would be benefit.
I think that is it. Wow, this has been
Okay.
a great talk.
Thank you, Sue. So I'll only end with the goal of a lot of these treatments and evaluation for chemoneuropathy. Even if right now in June 2022, I can't tell you we have good, effective ways to prevent it, and our treatments are not perfect for chemo-induced neuropathy. The goal of neuro-oncologists like myself and other oncologists is to really see if we can improve these symptoms for our patients, because they really do affect people's day-to-day lives. And for all of the gains that in many cancer types we're making in terms of treating the tumor itself, how to manage these toxicities from the drugs, and potentially, sometimes there's new drugs, new medications out there that are less causing less of the chemo-induced neuropathy. Strategies to try to work on that, we're very interested in. Okay, thank you, Sue, and thanks everybody for watching.